Good afternoon, everyone.
I'm having a little trouble with mine.
I think we are still solving the last technical issues, but I would like to welcome you to this webinar on challenges and opportunities to monitor new drug trends by civil society organizations. And this is the last of a series of webinars that we had this year in substitution for the European Harm Reduction Conference that unfortunately due to the pandemic could not occur in Prague this year. So the focus of this webinar will be to discuss challenges, limitations, and opportunities for civil society organizations to monitor new drug trends. But before we start, I just want to tell you a few practicalities. So how our seminar is organized. So we will have first a presentation from this about the monitoring efforts in new drug trends from the correlation monitoring. And MCDDA will present also how they are monitoring new drug trends. And then we will have 3 speakers from Spain, Switzerland, and Ireland, which are going to tell us more about the perspective of civil society organizations on how they do monitor new drug trends. And we will have some conversations in between, hopefully. But also after the presentations, we will have 30 minutes for your questions and answers and comments. I would like to ask you also to keep your cameras and mics off while not speaking, and you can share your questions and thoughts, please, in the Q&A. You might see in the bottom of your screen, there's a Q&A there. We could test that now if you are all awake and you see the Q&A. So if you are there, can you please just let us know, where are you sitting? Are you sitting in your couch or in the kitchen table? Or you can test if you want to see if you find the Q&A there. And in the Q&A also, when you are asking your questions, you can decide if you want to tell your name. So we will say your name and your question. Oh, someone is in the sauna, I see. That's exciting. And if you want, you can be anonymous and not share your organization. We will have a very interesting discussion with a very exciting panel of experts. And we know that substances are constantly emerging, and also patterns of drug use are constantly changing. So we see new and unknown drugs in the market. We see old drugs which start being used in different ways or by different groups. Or even this year with the pandemic, we saw that there was disruptions in markets. There were drastic changes in mobility, lifestyle, and changes also in the drugs people take and how they take sometimes occurred because of that. And this requires first an understanding of the new situation, and also to see what are the demands that are being unmet because of these changes. And so we can propose and provide new health and harm reduction responses for this. And in this context, we believe that civil society organizations can play an important role in monitoring new drug trends. These changes are often fast, and it's important to collect timely information, and also to have to be close to the ground, to be able to have a better understanding of the phenomenon. And CSOs have this access to people who use drugs, a very close access and information about developments on local markets, emerging substances, new routes of administration, new groups of users. So within our framework in correlation, we have been having monitoring efforts, and we have asked our focal points for 2 consecutive years now to collect informations and observations on new drug trends from the perspective of harm reduction services. And in this process, we learned a lot, but we also were left with many, many questions. For instance, can the current monitoring efforts like the early warning systems be complemented from the input of civil society organizations? And if yes, what is the best way for doing this? And how can we cope with challenges that we have? So this and other questions are questions that we are hoping to debate today with our wonderful panel. So without more, I would like to start introducing our first expert of the day, and that's Dan van de Gouwen. And Dan has been working for over 25 years in the field of harm reduction, drug checking, and research. Currently, he works at the Drugs Information and Monitoring System, the DIEMS, that coordinates drug checking in the Netherlands. He is also coordinator of the Dutch Harm Reduction Network and works on various international projects, including evaluations of national drug strategies and supporting evidence-based drug policies in Central Asia. And finally, he coordinates the Correlation Expert Group on New Drug Trends. Dan, the floor is yours.
Well, thank you very much, Rafaela, for this introduction. Hello, everyone. I will try to set up my talk. After 9 months, it's still strange to do this, to do a presentation on a full conference just by looking at your screen, but it will get used to it probably in the end. I will talk very shortly about what we have done in the framework of the Correlation Civil Society Monitoring of Harm Reduction in Europe. There were 3 expert groups organized, just to refresh your minds. One was overdose, the prevention and management. Another one was on hepatitis C. And this one is about new drug trends. And I have been coordinating this expert group for a while now. First, why would we, as civil society organizations, be engaged in such a thing as monitoring new drug trends at all? There are some advantages on that over existing monitoring agencies, which do a lot of good work, like EMCDDA and UNODC and others. But civil society organizations, NGOs working in the field, they have a much easier access to people who use drugs than people who are like me, sitting behind a desk all day. So there's easy access to new trends, new knowledge. And by doing so, they can rapidly pick up signals, more rapidly than basically any other agency involved in monitoring. And this rapid pickup also could lead to rapid responses, early interventions in cases necessary. For instance, in extra risky situations, one would be able to intervene much quicker than other organizations. And also,
Dan, just sorry to interrupt you, but your presentation is not currently being shared, and I don't know if you want us to share it or you will share it yourself.
Another try?
Yes, please.
It's shared again or not? Or maybe you can do it. Okay.
Can we do it then, Roberto?
I'm sorry for that. Maybe I can just continue just to save some time.
Yes, please go ahead. Your presentation is
okay.
It's there. If you can see, you can let us know which slide you would like to have it.
Okay. So despite the pros that I just mentioned, there are also a number of cons, things that civil society is not really good at doing monitoring new drug trends. One is that usually people working at civil society is not trained to do this work. It's very specific work and people have to be trained basically. Monitoring drug trends is really a time-consuming issue. And as we know, many people do not have a lot of time left just to do something else. Then an issue is also how to distinguish between single events, signals, and trends. We'll talk about that later. When do we consider something a trend, and when it's just, or otherwise when it's just something that passes in the night. And quite often civil society, not just specific for new drug trends, but more in general, they're often not seen as a very reliable, objective partner by stakeholders. So this is also a bit of a con. Roberto, if you can share, I'm now at slide 6. So we have been forming an expert group of experts basically throughout the European Union. The last time it's very dynamic, people come and go, and the current expert group includes actually several people who are also speaking today, which is Mireia Ventura of Energy Control, Magali Martinez from the French Observatory to the EMCDDA and many others, and also Tony Duffin has been part of the expert group, and he also will speak later. At slide 7, here you can see that we are now covering, the network is covering 35 cities in the European Union and abroad. And last year, in 2019, we developed the first questionnaire. And while we got back the results, we learned a lot. There were a lot of lessons learned. One major lesson was that the questionnaire was way too long. I think the whole questionnaire was more than 100 pages. So for the whole 3 or 4 topics, the topic of new drug trends already consisted, I don't know, 20, 15 or 20 pages of questions, way too long and way too detailed questions as well. So we changed that. Also, the geographical scope was way too wide. We asked questions at a local level, a regional level, as well as a national level. We have stopped doing that. And we also had a number of issues related to what exactly are we monitoring. We talk about new trends, new drug trends, but are we talking specifically about new psychoactive substances or not? So it was a bit vague last year, and we have changed it as well. And we came to believe finally also that questionnaire may not be the best tool to do monitoring of new drug trends by civil society. I'm now at slide 9 already. So this year's questionnaire was much different. It was much shorter. We only had 7 questions. The focus was on city level, basically the city where the focal point is based, and that's usually the capital of the country, of course, but not always. And the focus was no longer strictly on NPS, but rather on new drug trends, for instance, a new substance or a known substance, but used in a different way or by a different group, and so on and so forth. So it was really focusing on new developments in the field, new interesting things. And finally, we wanted to start piloting focus groups instead of questionnaires. Then the results. We did an analysis based on 35 responses in SurveyMonkey. 1/3 reported no changes whatsoever. This was their reply for our questionnaire. So that's quite a lot. A few non-responses, so they didn't respond at all. And then we have the issue with some focal points. So people who responded to the questionnaire were very active. They responded to each and every question very lengthy. While on the other hand, many focal points answered the questions, but with very little information, basically sometimes too little. Here you can see, I'm not sure whether you see it or not, but on this slide you can see that, for instance, the question, emergence, did you witness the emergence of a new unknown substance last year? From the 33 responses, only 8 said yes, we have seen a new or unknown substance last year, whereas the others, so it's 25, said no. This makes this, I've got a question for you at the end of this session, which is about the fact that maybe trends or new or changes on the drugs market happen not so often as we think. So maybe the time span for something to change is maybe longer than 1 year or not, because the number of responses here is quite low. Here's another one, I'll skip that actually. And here you can see that also for, did you witness new or different route of administration by your target group? Here also only 7 people said yes and the others said no. So from the responses we got, which was not optimal, we also see that only a few people see changes, see developments. So while doing this exercise this year and while analyzing the data, there was a lot of challenges that came across. I mentioned here a few of them. Probably the impact of the corona crisis on the response rate and the quality of the data, issues with interpretation of the data. For instance, what does it mean if a focal point returns many questions, many answers to questions? Does it mean that a lot is going on, or is it just something who's over enthusiastic to fill out the questionnaire? And also, what does it mean? Nothing changed last year. Is it easy way of people filling in the questionnaire, which makes sense. I can understand that in these times. Or did really nothing change? Another issue is the fact that when we talk about new substances, one of the questions was, do you know what the content is? And some people have, they filled out some self-reports. For instance, poison, rat poison was in there. It's a bit of a problem with, with the reliability of that, because it was not lab tested probably. So we don't know really how to deal with this issue. And then while talking about trends, we need to, and we haven't done that so far, so it's a bit of our mistake actually, is that we didn't define the trend. What is a trend? How long does it something have to happen, and so on? And what's the difference when you compare it to a signal or a single event? And I hope that my colleagues later will elaborate on that a bit. And then there's also the issue of the reliability of some answers. When for instance, from official documents at the UNODC or the EMCDDA, and then when you receive something from the civil society monitoring, which is almost the opposite of that, it's really a problem for us how to interpret those data. And then, but it's more general, is that there's a lack of capacity at the European Harm Reduction Network office to follow up on the questionnaires in case of difficult questions or unclear questions. We did it a bit, but not lengthy. So I'm at the end of my presentation. I hope you have seen it, and if not, you have been looking at my face for way too long. But anyway, the questions I would leave behind today are the following. As I mentioned already, the first one is that, well, maybe those trends, those changes in the drugs market do not happen too often, less often than we think. So maybe it needs a time span of maybe 1.5 years or 2 years or longer. If we have time today, I would like to talk to you about that and to get your ideas about that. And the second one is obvious. As I've shown you, we are not really happy with the response rate of many focal points. It makes sense probably in COVID time and busy other things and doing other things. But how do you think that we could increase the response rate and also the quality of the information that we receive back? So maybe we should use other tools, as I suggested, focus groups, or maybe even other things. I'll leave that at this. Thank you very much for your attention.
Thank you very much, Dan. That was a very concise, I think, a very nice summary of the challenges and the questions we are having. And I think that's a good way of starting with many questions so we can fire up our brains to keep discussing that. Now, I would like to give the floor to André Noor. And André is the head of sector of trends and analysis of the EMCDDA. And André would like to, if you would like to introduce yourself, and please take over with your presentation. We are looking forward to it.
Can you let my video start? Can you hear me?
I can. Roberto, can you turn
you have to unblock my video.
André's video, please?
It should be working by now.
Yes, I think it's working.
Excellent.
Should we share also your presentation?
Yeah, I'll put up my presentation in just a second.
All right.
Hi, my name is André Noor from the European Monitoring Centre for Drugs and Drug Addiction. Thank you very much for inviting me along to speak today. I was asked to speak particularly about the early warning system and NPS at the EMCDDA, but would also like to make some comments more generally about how useful and helpful it would be to gain insights onto new trends from civil society. But primarily it will be about the NPS. I'll try and share my screen now. Can you see that?
Yes, we can.
Okay, great. I tried to think a little bit, first of all, about what sort of parts there are in a monitoring system that we would be interested in. And I think there are three major parts. One is the identification of the event or of the situation that gives concern. Second is analysis of it. And third is finally communicating it. Because having identified it, you have to think very much how you're going to get that message out to people who may have to actually take action. The corresponding components within the early warning system for NPS at the EMCDDA are reliance, first of all, on collecting data from 30 national early warning system focal points. That's the 28, or now soon to be 27 EU countries, plus Norway and Turkey. Then there's a lot of work that is done internally and with our other sister agencies, which is an assessment of the information. And finally, there are three main parts in the notification of the information to other parties. The first is a formal notification to the network, and that starts monitoring on that NPS. The second is an initial report to the European Commission, which is to inform them of the basic understanding we have of the danger of a new NPS. And the third is a far larger report, which is a risk assessment, which is done and then again finally presented to the Commission in order to establish legislation. It's important about the fact that this process is intended to inform legislation. It also has a legal process, a legal position within the European Union. So there is a regulation in November 2017, which gave us slightly more power in terms of collecting the information from the countries than we do, for example, for other collections. So let me try and explain this a little bit better. I'm going to be repeating myself more or less over these three slides because it is quite detailed. And it's very formal. It's very formal because it's a process leading to legislation. So what do we have? Most of the information comes from these 30 national early warning systems. That's within the countries. They each basically act as an early warning system within the country, and their primary concern is for within their country. However, we share a protocol and we share guidelines and instructions on how to report. Within their own countries, they'll be collecting information from a whole range of areas, some of which will be civil society, but they'll be also getting information from treatment providers, from police, from customs, and the like. The information is then passed to the EMCDDA, which, when I say the information is passed to the EMCDDA, it's based largely around the chemical analysis of the drug. So the EMCDDA then tries and does as much analysis and investigation as it can to see whether or not this is a new NPS or whether it is actually just one that has already existed and needs to be put into that category. If it's found to be a new NPS, what happens is a formal notification is sent out on behalf of the member state that delivered it to the 30 national focal points, who then start investigating it in detail. The information from the national focal points is basically event-based data. They can report at any time during the year on an event, plus there's an annual larger submission, which describes all of the events for the year. Let me go down a bit. So having covered the first point, which is actually the identification, once it's got there, now we end up, the substance is being monitored across Europe, and the EMCDDA is busy trying to find other information on signals that suggest that this NPS may have a specific adverse health effect. So we'll be searching in all sorts of areas. We'll be relying on information from our own focal points. We'll be relying on open source information. We'll be relying on asking other networks whether they've seen any evidence of this drug or its consequences. And if at the end of that, we find that the drug is actually causing adverse effects, what we're required to do is to provide an initial report for the European Commission. And we do that with the help of our sister agencies and other parts of the EU, such as the European Medicines Agency, the European Chemicals Agency, the European Food Safety Agency, and Europol in particular, because they're involved a great deal. And from that point on, I mean, also at this point in the analysis stage, when I said we were calling on lots of other networks, we'll also be looking at other areas where there is evidence of analytical evidence of drug use. So for example, one of the big ones, which I'm sure Maria will be talking about later, is from the drug checking network, because there we're also getting data that has been analyzed chemically. So after that analysis stage, what we then do is we're in the hands of the Commission. The Commission can then write back, and if it considers it serious enough, they will ask us to perform a risk assessment. And the risk assessment takes us a lot longer. It takes us generally about 13 weeks. This is just a representation of the three different areas. We find, starting on the left-hand side, we've got the early warning. So we have an analytically confirmed detection of an NPS. We go for a formal notification. We then do some analysis. Everybody's trying to monitor it. We look at other sources. We then do an initial report. And if they come back and say that, yes, we should do a follow-up, then we should move on to the second part, which is the risk assessment. We then launch detailed investigation, and it has to fit a specific structure, that we have a defined way in which the thing has to be done, looking at both the environment in which it occurs, does the drug have other uses, all sorts of issues that maybe will impact on the decisions of the Commission. And then we submit it to the Commission, and the Commission then comes back with its decision after a certain period of time on whether or not this drug is actually should be made, should be reported on the list of illegal drugs. That, in a sense, is probably the most formal type of early warning system reporting that we have, and it's around specifically NPS. So just some characteristics. It's formal and defined by legislation. It's reliant on forensic toxicology for detection. It requires the participation of the national early warning systems, other networks, other sources of signal detection, EU agencies, and the Commission. The end product can be legislation by the Commission. If you're interested in further information on it, if you look at our website, there are many, many different publications on it. And these are on the specific drugs, these are initial reports. But there are, for example, descriptions of the actual process, which I was asked to concentrate on, their guidelines, which is effectively a protocol. Having said that, which was one side of the talk, some of my colleagues here will know that I also have an interest very much in how we can gain information on new trends from people who are actually working directly with drug users, and to be able to understand not so much what has happened in the past, which is what a lot of monitoring does, this bit outside, but importantly to try and recognize things that are coming towards us. And here it's, I suspect, far less a science but an art, and that we desperately need to add some sort of structure to it to make it work better. Hearing Dan's description of attempts to collect information on new events, it mirrors very much our experiences as well. It's very difficult. And we've tried, for example, and when we're talking about various networks, I tried at one point a couple of years back up with drug consumption rooms. I know Correlation has been working on this very hard for a large number of years and has produced some excellent guidelines on how to collect information or questions. But actually putting this into practice is very difficult. I think largely because practitioners frequently don't have enough time to be thinking about the larger picture when they're actually working face to face with quite chaotic situations in order to help real people in front of them. I think also that perhaps the methods we have been using need to be adjusted slightly, but we've tried surveys as well. And I just make one suggestion in this part before I open it up to any questions if anybody has, is that, before I end, sorry, is that we were thinking also whether focus groups would be a good idea, and there are examples of these across Europe where people have done work on them. We also see very useful examples in of city level monitoring in the Netherlands, in Germany, in Norway, and there are difficulties in both of these when you try to extend them to a network across many countries in Europe. It seems to make sense on a local level, but once you scale it up, it becomes very, very difficult. And we were thinking again around the idea of focus groups, but we're also thinking that perhaps, and this is just a question for you, is that perhaps rather than leaving questions open, if we identify a topic that we're interested in, I mean, a perfect example at the moment would be the issue of methamphetamine, which historically has affected a limited number of European countries, but we're now very aware that there's an increased production in Afghanistan, and we're seeing increased seizures in countries like Turkey, countries in the Middle East, and others. We're also seeing small production here in Europe. But if we were actually started with a question rather than have you seen anything, an open question, then perhaps we would get the countries that did have information or people who did have information involved. And you won't be able to get everybody involved, is our experience. We can't even get everybody involved with things like treatment in some instances. So I've just an open question is that maybe focused questions would be a better way of collecting information on new trends using information we already have. Thank you. I've taken way too much time. I'm very sorry for that, but I hope it was at least a little informative. That's it.
Thank you very much, Andrea. And you didn't take, it was perfect timing. You didn't take at all too much time. I would invite also Dan, if you could turn on your camera, please. I think we have a few minutes for some questions and answers. I'm not sure who's sharing the screen. Could you, whoever is sharing the presentation, maybe you could, yeah, so we are a bit more visual for people. Thank you very much, Andrea, first for your presentation. I think it was very nice to know more about how the early warning mechanism actually works. And also I think it's very interesting. And I think that's what we were expecting, to have this very honest conversation about challenges and how we can cope with them for monitoring new drug trends. And there is one question from Alexi Hoopley that I would like to share with both of you. And Alexi is asking, do you know if there are any projects that use various digital methods to track new drug trends, perhaps by focusing on different social media sites? What is your experience with that?
Well, we have a large-scale experience with that. We have been monitoring, still are monitoring drugs fora, where people discuss all kinds of drug issues. So we have done that manually, but for a number of years now, automated. So this is one thing to learn about new trends, but it's usually on a national level or even broader. Another thing that we have been doing was Telegram as a source to find out about popularity of drug offerings, mainly on Telegram. We have done that during COVID times. It was quite interesting. The article will be published shortly. And also, we have restarted our collaboration with the Friends Monitoring Center and also our Czech friends. We did that before in the iTrend project, and we have now we start now with web shops, scraping web shops on what is offered there in terms of MPS and synthetic opioids and stuff like that, just to find out whether there's an increase in offerings and how things are running there. So yes, Alexi, we are doing this, but it's difficult to frame that back to a local level, because the internet is, it's global, as we know. So it's really hard. Basically, the same way as Andre already mentioned, it's hard to interpret those data in the best way.
Thank you. Then, Andrea, would you have anything to add to that?
We don't have as much experience, for example, in scraping of forums. We've tried it a little bit and had some difficulties there. But what we do is we have a very for us important project on monitoring the darknet, and that's in order to see new products, but also to get information on prices, because prices are an important component of the market. But there is an EMCDDA publication on monitoring the darknet, and which is available on the website if you are interested. Another area where we have found and thought of at one point was using Facebook, and we use Facebook advertising, for example, very much in the enrollment or the advertisement of online web surveys. But I think this is a very large area, and also unfortunately, well, not unfortunately, but fortunately, I think it is important also to consider some of the ethical issues around where should we stop when it comes to using information that people may not be aware that they're making public. So you can use, until recently, you could also use Facebook to where people were and locating their location. But I think it's something that we looked at and found ourselves very quickly in this sort of uncomfortable area of knowing when were we actually stepping beyond the ethical grounds. That's all, really.
Those important questions we have to ask ourselves. There's another question for you, Andre, that is, what is the time frame at the EMCDDA for the early warning?
The time, it's an event-based, the actually early warning system, where you collect the data from the 30 national early warning system participants. It's an event-based system, so they submit electronically, and now, previously it was by email and the like, but it's open all the year round. It isn't done on that, and there's just an annual report as well. So they will start the process as and when events occur that demand it. But it isn't as it is quick, and it's a lot quicker than a lot of the monitoring that we do, because our monitoring is unfortunately very slow, and that's a big issue. And this is also, I think, an issue where civil society could really help. But it's it's quick in terms of our other monitoring, but it's still, you saw that it takes 13 weeks to say that the risk assessment, to get the risk assessment done. It could well be another 10, 13 weeks before we got to the risk assessment, even if it was proving to be quite dangerous. Though the EMCDDA will issue warnings and reports to the members of the network if they find a drug that is causing serious adverse events. So, for example, a couple of years back, there was a drug that had resulted in a number of deaths in the north of England and in, I think, Netherlands as well, and other European countries, where we did try and issue alerts to which, how they actually get out is into the public domain is sometimes tricky, because you don't want to encourage people, and sometimes people see an alert as an advertisement, but and so you have to try and try and be balanced in it. But we do try and act as responsibly and quickly as possible.
All right, thanks. There is, I think, a last question before we go to our next speakers, and it's from Natasha Milenkovic, sorry if I'm not pronouncing correctly, from Switzerland, and is asking, do some preliminary indicators regarding the term of trends exist? Don't know which one of you would like to address that.
I am not aware of that, so this is one of my questions. I assume they are there, but so far we haven't came across them. But probably EMCDDA has some standards or indicators defining a trend, because we have been struggling with this issue, but I know that many others have been or still are. So I assume that Andre and his colleagues have some knowledge about that.
I think for me, there are sometimes multiple uses of the word trend. If we look at something like if we look at something like the number of entrants into treatment in a country across 10 years, you can measure a trend using various statistical methods. It's, you can fit a line and see if the coefficient is statistically different from zero. There are various methods you could use depending on the nature of the data. But we also use the word trend to mean new event, new thing. And there, for us, we start thinking also about lead and lag indicators that might be an indication of something that may be coming, and indicators that actually only reflect a change that has occurred after some time. So for example, for us, we commonly think of seizures as one of the lead indicators, in the sense that it will, if we see that cocaine seizures are going up, it could well be because of activity of law enforcement, but it could also be because there's more cocaine coming into Europe. And what we will then do is we'll start looking in the other indicators to see if there is any evidence of that. Okay. A lag indicator would be something like prevalence of use, which would come only from a survey that had occurred at some point later on the time frame. And we probably will only just start seeing, for example, cocaine prevalence going up amongst young people or whatever after 2 or 3 years. But so that might be a lag indicator. But around this, but I think also around, in the first instance, when we talk about trends of an indicator, this is also within this monitoring field quite difficult because of the nature of the data. It's subject to a lot of biases, and we would have to you have to actually do it on a more or less indicator by indicator basis. But we would love to share or learn from other people on how, if they have any better ideas how to do it.
Thank you very much, Andre. I think we will probably hear more about that also from our next speakers, and we will be able to discuss further. I would like to thank both you and Dan for the presentations and for this first part. And if I could ask you to switch off your cameras now, then we would go for our next speakers. And so, Alexi, I see you have another question, but we will save that for later. Or if Dan or Andre would like to answer that, or some of our other speakers would like to answer that in the Q&A. Otherwise, we will talk about it live later on. And now I would like you to meet Tony Duffin, if you can switch on your camera, Tony. And Tony is the CEO of Analifi Drug Project, a position he has held since November 2005. And prior to this, he held a number of senior management roles in the harm reduction field, including playing a key role in opening Ireland's first emergency accommodation for young people who inject drugs. And sorry.
Can you see me?
Yes.
I put my slide up. I've got a couple of slides. Is that okay?
Yes, that's great.
Yeah.
And
okay.
All right, and also Ireland's first. You have so much to to talk about you. So he also opened Ireland's first wet residential service for entrenched street drinkers, and played a key role in advocating for the misuse of drugs, supervising Injecting Facilities Act in 2017, which was signed into a law in May 2017. So, Tony, if you take the floor, please.
Thank you. You can see and hear me okay, I hope.
Yes.
Hi, everybody. It's always very strange doing these things, even though we do a few of them during the course of the weeks that pass. I'm ridiculously happy to be here. I always enjoy being with the Correlation Network and other harm reductionists. I've got a couple of slides just to try and keep me on track. I'm likely to go all over the place. I've titled this one, Swallow Doesn't Make a Spring. You know, the idea, I think Dan was alluding to the fact, the idea that one event does not necessarily indicate a trend. And I think we have to remember that when we're looking at these things, particularly, I suppose, what I'm going to talk about. The pictures you see now here on this particular slide are from the city of Limerick in the southwest of Ireland. Sorry, midwest of Ireland, I should say. In July 2020, during the pandemic. I think I put them there because Limerick City is small. You know, sadly, it does have a significant drug problem, but the trends are very clear and can be identified very early on, particularly by the team of Analyphi Drug Project, the team I work with, harm reduction services. They get told what's going on. So these are photographs of people showing the drugs they bought during the lockdown, for example. Heroin became as cheap as 10 euros a bag of heroin, normally 20 euros. 2 rocks of crack were being sold for 25 euros, so 12.50 each. Only a couple of years ago, a rock of crack was sold, a bigger rock was sold for 50 euros. And then there was other things during the lockdown, pick and mix, 35 euros a bag with benzodiazepines and Z-type drugs and maybe heroin. You just got a selection for 35 euros. So, you know, these things come up, and harm reduction services know these things very early on. That's going to be the kind of theme of what I want to talk to you about. Just to say, the Analyphi Drug Project was the first harm reduction service in Ireland, founded in 1982, and we provide direct services in Dublin and the Midwest of Ireland. And I think, you know, it's very interesting coming in just after Andre, who's talked about this very formal approach to learning about trends at a very European-wide level, and I very much enjoy engaging with the EMCDDA and those things. But I'm going to talk a little more about sort of local knowledge and intelligence, if you like. So I hope this will move to the next slide. Perhaps it will. Let's see. It'll move in a moment, I doubt. There we go. So this is the second slide, the only other slide I have. I want to talk to you about the 2015 HIV outbreak amongst people who are homeless and who inject drugs in Dublin city centre. I could have chosen a number of different scenarios and different trends that we know about over the years, but I picked this one because the timeline is really quite clear. So in August of September 2014, we noticed that Analyphi noted that service users had been presenting with increased anxiety and agitated behaviour due to what was described as MDPV, methadone or methamphetamine use. People didn't really know what they were buying. They were buying from dealers what was being sold to them, ice, methamphetamine, but they didn't really know what it was. We certainly noted that increasingly over a number of weeks, more and more people were telling us that this was happening, and we immediately increased our advice around stimulant use. There was a lot more injecting. People were injecting every 2 hours. Many people were injecting every 2 hours, and there was more blood involved. There was more risk involved in terms of injecting practices, bloodborne viruses, etc. Unsafe sex. People were having more sex, so we needed to do more interventions around safe sex and such, condom availability and such. So that was something that happened in the moment. in August and September of 2014. In February 2015, it was identified an outbreak of recently acquired HIV infections among people who inject drugs was identified in Dublin. A multidisciplinary incident team was set up by the Director of Public Health in Dublin to investigate and respond to the increase. So in February, it was identified that amongst this client group, HIV increase, a significant level of HIV increase had occurred. In October 2015, an epidemiological investigation and case control study was undertaken by the HSE, and the investigation was the first evidence of an association between injecting snowblow, which was another mephedrone and such, because there was different drugs going around, but snowblow or ice and recent HIV infections, they were associated. And then in June 2016, charities marked Irish AIDS Day with a harm reduction campaign for people who inject snowblow, and the ARSE campaign was a harm reduction and HIV prevention campaign developed by the Analyphi HIV Ireland North Inner City Drugs Task Force, and the campaign aimed to help address increasing HIV diagnosis amongst injecting snowblow. The reason I mention all this is because you can see from the timeline that, of course, things were done, but in terms of finding out exactly what had happened, it was October 2015 when we finally caught up with ourselves. So harm reduction, frontline service, didn't know exactly what it was that people were taking, but we knew that it was a stimulant and we knew that we needed to act. And that's really important. And that's going on across Europe. It's going across all, in different cities, urban centres, rural spaces. This kind of information is really, really important. I'll come back to that. But of course, it would be disingenuous to say that somehow there wasn't information being gathered. So I'll just recap on the kind of things that in terms of knowledge that we do get in Ireland. So broadly speaking, there was a lot of relevant data gathered. For example, treatment data gathered by the Health Research Board, our colleagues there, who feed into the EMCDDA. Needle and syringe program data gathered by the Health Research Board. Drug-related deaths index, which is always 2 years behind on its data because they have to ratify how people had passed. But again, very useful data. And the EMCDDA drug report includes data gathered by the focal point in Ireland. So information is there and it does inform policy. So I just want to mention those things because they're very, very important. But then there's also just to mention this, because if anybody who's joined us today doesn't know about it, they should look at the EMCDDA's TrendSpotter methodology. It's very, very useful tool, and we certainly have used the methodology in recent times, and I could have done a presentation on that around street tablets. We were trained, staff at Analyphi were trained, we worked with Cork University, and we implemented the methodology. I'll tell you quickly about the methodology, but it took us 8 months to do a report, and it's online. So just to say, the EMCDDA recognises the lived experience of people who use drugs and the experience of service providers adds rich and important qualitative information to the quantitative data it collects. That's really important to say. And the EMCDDA's TrendSpotter methodology, which uses multiple social research methods to explore topics of concern, has changed my perspective on how EU organisations can meaningfully engage with civil society. The methodology can provide more timely information on what's happening on the streets at local and national level and informed responses to these issues in as close to real time as possible. And I think I would thoroughly recommend that people, if they don't know about it, go and look at it and do use that methodology. At the moment, Irish government is using that methodology for its rapid assessment on the impact of COVID on drugs, services, and people who use drugs. So it's a very, very good methodology that can be used by civil society and by states. So thoroughly recommend that. But I do think there's a gap, and I do think that I just want to mention that. I want to talk to you about what I would loosely call sort of intelligence-informed harm reduction responses. People who engage with harm reduction services have important real-time information about local drug trends. And it's rich qualitative information. If it's in its raw form, it's not research, but it is valid information if treated and presented in the right way. And I'll just in terms of it, I suppose the idea is that we should develop intelligence gathering networks locally, a system through which information about drug trends can be collected for the benefit of responding to local drug trends and able to inform national drug policy, a real-time system of gathering information through the use of more than one interrelated source. So I come back to my point, one swallow doesn't make a spring. This must be interrelated information. And, you know, we don't have that. In Dublin, we would have the information that Liffey has, and then other colleagues like Emergence Key or other agencies. So I think we can really look at that and keep it simple. We should, harm reduction services and drug services should pick up its authority and use that information wisely, and just look at how they can use that information. Also, just to say, in Ireland, we do have an early warning system, and it includes all partners. It's called the HSE, the Health Service Executive Risk Communication and Alert Channel. So I just want to acknowledge all of the good work that's going on, but also acknowledge the importance of harm reduction services, the relationships we have with people who use drugs, the information that we can garner very early on, and that we really need to use that better. We just need to use the information better locally so that we respond quickly, and then to inform other national policy responses. So that's really what I was going to talk about. I hope I haven't gone over time.
Thank you very much, Tony. You're very much on time. That's great. And I would like to introduce then our next speaker. If you can turn off your camera, Tony, and Mireia. So Mireia Ventura is a pharmacist and a PhD, and she is working as a director of the Drug Checking Service of Energy Control since 2007. She's a collaborator also of the IMIM, if I pronounce correctly, the Instituto Municipal de Investigaciones Médicas, directly involved with the scientific diffusion of novel psychoactive substances. And Mireia is also a TEDI work manager since the beginning of 2011. That's the Trans-European Drug Information Project, which is a network of European fieldwork drug checking services that share their expertise and data with the European monitoring and information system. So we are all very much looking forward to listen to Mireia's talking about their experience.
Hi, hello. Thank you, Rafaela, for the introduction, and thank you to Correlation for the invitation. In fact, it's nice for me to explain about our experience in monitoring, because finally at the beginning, we were not reaching this objective. When we were talking with my colleague, Claudio Vidal, about how to explain our experience in this webinar, finally, we draw the conclusion that we are doing a type of preventive monitoring, or at least a monitoring that came from our harm reduction work. I would like to share 2 or 3 slides, only some pictures, to explain a little bit how we are working. I think that this would be interesting to understand the specific way. So this is not. Rafaela, can you see it?
Yes, we can see it, but it's not in presentation mode only. It's we can see the whole screen. Yeah.
Yeah, because I was doing with Google.
Now
perfect.
We can see it.
Yes.
Yes. Perfect.
Okay. So this is the place where we are working, or at this time I need to say where we were working, because of course in this COVID situation we don't have the recreational settings. But our drug checking service were mainly set up as a way of connecting these people, because the people who we are reaching, these people who are taking drugs as a recreational part, no, as a way to have fun and to go outside and everything, these type of people are not really concerned about their health. So you need to find something that can be really interesting to ask these people to connect with you again. Because we understand that we have a general prevention, which is a prevention that tries that people are not taking drugs. But when these persons are taking drugs, it means that this type of prevention falls. So then you need to find another strategy to connect with these people and to give them specific information about drugs. Because if they are using drugs, they are on risk. And of course, they need this type of information. So they are very concerned about the adulteration of drugs because they are totally aware that they are in an illegal market. So if you can provide with a system, with information that can explain them which type of information, which type of drugs, which type of adulterants, which type of dose, this type of specific information is much more useful for these persons. It's not the same to talk generally about cocaine than to talk about the specific composition of the cocaine that you are going to take and the specific risk that you are going to take with these mixes, or the specific risk that you are going to take if you take more dose or less. So when we are connecting with these persons, we are gaining their trust, because civil society organizations, one of the skills that we have, and one of the, I would say, one of our strongest points is that we can react very fast to the things that are happening. So in the beginning of all the type of interventions, of this type of risk reduction interventions that we call, energy control is only a part of a group of a big network. It's called New Network. We are more than 25 organizations from Europe that we are collecting information, that we are providing this type of strategy to recreational settings. And this type of prevention, this type of interventions is totally based on distrust, because in the beginning, when this was in the beginning, late 90s, in the beginning of 2000, most of these organizations were beginning, and this was we had a big problem with MDMA pills because they were adulterated with a substance that is called PMA, and this substance was enough to kill persons. So at this time, only really simple and specific tests that could detect if these pills have MDMA or not were enough to gain the trust of the people who were taking drugs. And this trust then is totally in favor about the type of intervention that we are doing. And then we are working with our clients with this trust relationship, in terms that they trust with us to give us the substances that they want to take, and they trust us with the results that we are giving. Also, drug checking services are always considered as objective information, that this is important, but at the same time, they also trust with the information and advices that we are giving back to them. And with this trust also, the impact of this monitoring is also preventive, because if we are detecting some adulterants, if we are detecting potential toxic substances, people are reacting in accordance of this type of advices, and most of people are reacting very positive. This, for example, is an example of one intervention in a big festival. This was a big festival in Barcelona, and the type of techniques, every country has their own possibilities. Of course, if you have more money, you can implement better techniques, but at the same time, the most important thing is to be able to give the results at this population, at these clients, at the same place that they are going to take these substances. Then after each event, for example, we are doing this type of impact analysis, and as you can see in this slide, we can ask, according to the result, what they are going to do. And for example, this was a survey that we did, or an impact study that we did 2 years before, where the adulteration of drugs was not very high. So we can see that more than 50% had the expected substance, and of course we don't have an impact in terms of not using these substances, because these people were with intention of using these substances. Then the 44%, they found that a part of the expected substance they found an adulterant. With this adulterant, mainly these are, for example, cocaine. So people are looking and finding the substance that they were looking for. And we can see that 64%, they also were thinking about not using this substance. So finally, also when you have a period with low adulteration, also this type of things happen. That people are being more strict and they are looking for these pure products. But at the same time, we also found that these 36%, they would use this substance anyway. Also, when you are detecting adulterant, you can talk specifically about this adulterant. Of course, it's not the same. There are no specific adulterants of cocaine that are quite concerning, like levamisole, phenazepam, that, for example, to find an anesthetic, local anesthetic inside cocaine. But at the same time, I think that the most important thing is this 5% of unexpected substance. So that means that they were not finding the substance that they were looking for. And the numbers say to us that, okay, this is important in terms of impact because 100% of this person declared that they will not use this substance. So the way that also we are working when we are working at festivals, for example, these are several pictures of how we are diffusing. We set up like a small early warning system inside every place that we are testing. And the first picture, the picture of the left, I think that has more than 20 years. So finally, the resources that you have are not important. The most interesting thing is to show the information that you are getting inside your testing, inside your service, to show to other persons. Because if you want to have impact more than the impact that you can have with the persons that you connect and that you can contact, you also need to spread this information, to diffuse this information, because you can contact with several persons at this festival, but you need to be aware that you cannot contact with most of the persons that will be inside this festival. So the way that you are diffusing your information, it will mean the impact that you will have later on with your intervention. So finally, with pills is something easy because they have a logo, they have a shape, they have a color. So finally, only with a pen and a piece of paper, you can explain what you are detecting there. Also later, later on we could use some printers to do it more beautiful. The next picture has not less than 15 years. But then later we were improving, of course, our way of diffusing. You can also use the screens, and also in big festivals we are preparing a site, and inside this site, using QR, they can have access to all the results that we are collecting from this festival or from this event. And then something is happening. Once you are setting up your drug checking system, you can see that in the beginning you have mainly in the 2, maximum 3 hours, you could map all the pills that are inside this festival. And also we are asking on purpose which pills are bought directly in this festival to know perfectly which are the ones that needs to be better monitored. And then later you can see that in 3, 4 maximum hours, the pills that are adulterated or fake pills are disappearing from the service, which means that no more persons are bringing this type of samples to your service, which means that indirectly you are affecting to this local market of these fake pills. And also at the same time, you can see perfectly how at the end of the festival, these fake pills can appear crushed in powder like cocaine or like speed. So finally, also this is another sign that our intervention is crucial in this sense. Then also,
Mira, sorry to interrupt you, but if you can wrap up, then we have time also for more discussion at the end. Thanks.
Okay, but I thought it was 10 minutes. It's okay, yeah.
Yes, we are at 11
okay.
now.
But I can finish here. It's okay, Rafaela.
No, you can wrap up whatever you.
Okay. So this will take me only 2 seconds. So finally, also when Of course, the more focused or the more located is your word, the better, but also sometimes you need to think, for example, with MPS, you need to think that this is in a worldwide level, no? For example, this happened with an MPS that was mislabeled, and it was sold a substance 20 times more potent than the substance that was labeled, and then this provoked several deaths. Then, thanks to the collaboration, no, in networking, mainly with Airwid, this was also amazing to see. You know, this happened in 2009. It was amazing to see that once Airwid was, you know, sending this information that this is happening, and we are trying to find this specific sample to see what is happening. Once this big network send this information, in 1 hour we received the sample that was looked for, and then once it was analyzed, then we could identify the substance that was involved, and once this was published, the death stopped. So it's really the impact that you have when you can really know and see what is happening inside, and diffuse and explain to your clients or to your target group, you can see the impact of this monitoring or this defining of the new trend of this product or of the drug use that you are using. Thank you.
Thank you very much, Mira. It's very nice to see more how monitoring happens in practice in a drug checking service, and how important that is also for people who use drugs to be able to know what they are using. I would like to introduce our last speaker, and then we can go for a round of Q&A. And our last speaker is Dominique Schodi, if I pronounce correctly your last name. And Dominique has nursing education and worked for several years in harm reduction services. After studies of philosophy and history, he was in charge of numerous harm reduction projects on a national level for Infodrug, which is the Swiss Office for Coordination of Addiction Facilities, and was also the national focus point for correlation in Switzerland. And since the summer of 2020, he has been managing the safer party street work of the city of Zurich, a service that focuses on harm reduction for recreational drug users. And Dominique will show us more what the safer party street work is about. The floor is yours, Dominique. Thank you.
Thank you very much. Can you see my presentation?
Yes, it's also, yes, now it's perfect. Thanks.
Okay, thank you also from my side for the invitation. While preparing this presentation for the webinar, I was also a bit struggling with the question whether to call this a trend or not. Unfortunately, we don't have time to go deeper into, let's say, questions of philosophy of language about meaning and of words or something like this, but I think we have good arguments to call this a trend, what's happening right now in Switzerland, in a way that Andre described before, because it's not a singular, isolated event. It happened in different cities in Switzerland, so I think we have good reason to call this a trend. I want to say first a few words about Safer Party Street Work, about our organization, then try to describe the phenomenon or the trend a bit in a more detail. Then I would like to talk about the main findings that we have made in the Drug Information Center, City of Zurich. Then I'd like to talk a few words about the very important perspective of users that visited our service. Then I try to explain why this trend seems to be exclusively something that's happening in Switzerland right now. And then finally talk about the role of drug checking services in monitoring a trend. For those who still can remember the golden age of pre-COVID, these are some images from our mobile drug checking services. So Safer Party Street Work is a service that's run by the City of Zurich. We have the, as I already told, Drug Information Center with a stationary, so a fixed site drug checking service, and also a mobile drug checking service in non-COVID times. We have also an outreach street work project and a low threshold counseling office. At the Drug Information Center in Zurich, we are testing around 2,000 samples a year. So, talk about synthetic cannabinoids in cannabis flowers in Switzerland. Synthetic cannabinoids have been circulating on the Swiss market for now a bit more than 10 years, which might be similar to other European countries. Originally, they were mainly consumed by so-called psychonauts, people who like to experiment with very variety of different, usually NPS, and they were often distributed under the name Spice in the ClearNet or in so-called head shops. They were and are still attractive for people that are living in settings with, let's say, a high control pressure, because synthetic cannabinoids are not detectable in standard urine tests. In 2019, synthetic cannabinoids first appeared as an additive on cannabis flowers in drug checking services. Since the beginning of 2020, so this year, and just to highlight this, it started already before the first lockdown, so it was already in January that we saw an increase of inquiries. So users came to us, contacted us because they had very, very unpleasant side effects when using cannabis. And we started also to talk to police and to custom, and they also saw an increase of these synthetic cannabinoids in powder or liquid form. So what did you see in the Drug Information Center in the city of Zurich? We had more than 150, let's say, suspicious samples. In this year, we found, or let's say our partner lab found synthetic cannabinoids in a bit more than half of those samples. You can see we found in those different samples between 1 and 5 different synthetic cannabinoids. So the maximum of synthetic cannabinoids in just one sample were 5 different. We have no idea what's gonna happen if you consume this. And what was very, very interesting for us also for the explanation or the interpretation of this phenomenon or this trend was that almost every sample that was tested had an amount of THC of under 1%. And that's what we call in Switzerland legal CBD weed. I will come back to this a bit later. Very problematic is that you have users reported us that they are no external distinguishing characteristics, so you can not see something regarding the price. The average price was the same as it was for illegal cannabis. It was around 10 francs per gram. You cannot smell it, you cannot taste it if you smoke it, you cannot trust your source of supply. So we had samples from local dealers, we had samples from people who bought it from street dealers, through private networks. We had samples bought in the dark net from Swiss vendors. So you have no possibility to see it like externally if there are synthetic cannabinoids inside or not. And compared to the psychonauts, as I told you, the problem is that there is a systematic misdeclaration at purchase. So cannabis users just expect to smoke their usual illegal THC cannabis. Not going into detail, this is just data from the first 6 months in 2020. For those who we found the most one, the EMCDDA published some risk assessment reports. So what's the problem effects of those synthetic cannabinoids? Since the substances are very potent because they are so-called full agonists, the risk for a potential fatal overdose is very high. The substance is applied to flowers with spray heads. It's called, if you are familiar with that, so-called airbrush method, which leads to uneven distribution and so-called hotspots on the flowers, where the concentration is particularly even higher, and the risk to get an overdose from the same sample, so 1 to 2 persons could consume from the same sample, and one could risk an overdose and the other not. So far, the phenomenon seems to have established itself principally in Switzerland. We have already heard of some cases in Germany, but from what we have heard from our partners in Europe, which means the EMCDDA, the Correlation Network, and also the TEDdy Network, there seems to be quite isolated cases outside of Switzerland so far. So, drug checking services can additionally characterize trends like this trend on synthetic cannabinoids also by systematically asking users about their experience. We developed a standardized questionnaire to ask people who are visiting the Drug Information Center what effects, what side effects did they have while consuming it. As you can see, it's sometimes very severe side effects like nausea, vomiting, palpitation, dizziness, sweating, paralysis, and also on the mental level, they had panic attacks, they had real hallucinations, I mean, not pseudo hallucinations, as you may know it from, for example, LSD, and also dissociative sensation. So not something that you want to try again. Okay, why does this happen only in Switzerland? When we're talking about trends, usually we see similar developments. For example, the increase of purity of cocaine, the increase of MDMA and ecstasy pills. We see similar phenomena in other European countries. Not for this one, and we believe, so we are convinced that this trend has to do with a specific situation on the Swiss drug market or Swiss cannabis market. In 2011, the limit value for THC was increased by the national government. It is therefore much higher than in European countries. Most European countries have an average of, I think, 0.3 or 0.4. And in 2016, there was a real boom with so-called CBD weeds, so cannabis with less than 1% THC, and was distributed as a tobacco substitute on one hand, or either as a lifestyle product. And quickly, there were far too many producers on and the market just collapsed beginning this year. As you can imagine, prices decreased from originally 6,000 Swiss francs to approximately 2,700 francs for this legal, so-called legal CBD weed. And also with the abolition of the tobacco tax starting this year, prices fell further. So all of a sudden, there is an oversupply with a legal source product that can be treated with synthetic cannabinoids and can be resold around, I would say, 5 times more than bought. So it's quite attractive for people who are looking for quick profits. Now, what is the role of a drug checking service regarding this trend? I think we are we're able to detect phenomena or trends on a really early stage. So we have early informations of any smaller changes on the market. We are orientated, as Mireia already mentioned, at the level of consumers. So it's really public health relevance because we talk about and we know about what people really are consuming. And I think what is important too is that we always have a monitoring on a substance level, so we can talk about different synthetic cannabinoids, but also we can talk about the user level, so what users expect, what's their motivation, what are the effects of their consumption. And we have a lot of additional information, as also Andre mentioned, for example, the price. So we know that the average price of those misdeclared products is the same as for just standard illegal cannabis. Also about the source, where did they buy their substance, also about symptoms. If you have an NPS where there isn't hardly any information, it's quite important to have information about symptoms. And hopefully we have an indirect feedback on the market. We always told users with positive samples to go back to their dealer and tell them, confront them with this new information. So,
sorry, Dominic, to interrupt you, but if you could wrap up.
Yeah, it's the last one.
Thanks.
Just as consequences for us, we in the city of Zurich, we were luckily in the situation that we could quickly extend our drug checking service. So we have now a service only for cannabis on a weekly basis. We also still do alerts for consumers and professionals if we find some positive tested samples. We are networking with other services such as youth workers, toxicological information systems, Institute of Legal Medicine, addiction prevention centers, and so on and so on. We're also publishing, not only us, also other colleagues in Switzerland, reports and fact sheets. We had the opportunity to publish a partner report with Correlation together about this phenomenon. And we're still monitoring further developments on the market to see how, if this trend is going on next year, or was it just a trend or a phenomenon for 2020 and 2019. So thanks for your attention.
Thank you very much, Dominique, for this very nice presentation, and to know more about how the service works there and how the monitoring process works. We have a few, I would say around 10 minutes, if we can extend a bit for a discussion. I would like to invite all the speakers to turn on their cameras. And I would like to address questions more to Mireia, Tony, and Dominique, but please, Dan and André, also if you have questions to the other speakers, that would be great. So I don't see any questions in the Q&A now. If you have, please post them there and we will talk about them. But I would like to ask just a starting question, because it was very nice to see, I think we are talking about a level, like a more practical level, on how you can implement this process of monitoring. And I would like to know from you, what are the things that you think it works? So the challenges you have, but also what do you think it works in terms of how do you get this information? What are the best methods? What are the best people to ask this? And I was also thinking, okay, when we are talking about drug checking services, you have a lot of things in place, but what if we want to monitor new drug trends where there's no drug checking services? How can we do that? Do you have any ideas for what we could do? Please feel free.
If I can begin, because also I would like to answer the question of Dan, because also I think that it's important to think about, we were talking mainly, I think Dominique and me and I, about a specific trend or specific result of a product. But then to talk about drug trends, you need time, because as Dan pointed out, this is not easy to see. So civil society organizations can give a quick answer of what is happening. And if you don't have drug checking services, you have other ways to contact people. And finally, with this exchange with our target group, we can collect a lot of information. But at the same time, of course, you need to triangulate all the information to be sure that the information that you are receiving is a information that is a trust information, not from the level of trust that they have with us, but sometimes there are a lot of myths in the use of drugs. So finally, to know if what you are detecting now today in your city at your drug checking service is something extended to your region or something extended to Europe, or then you need to triangulate a lot of information.
Maybe just in addition to what Mireia said, if you have any service, even without drug checking service, even without the drug consumption room, let's say you have contact with users and you know something about them, and maybe sometimes you should also challenge the concept of evidence, let's say, because if 20 or 50 people tell you something about a new phenomenon, about a new trend, about what's happening on the local market, it is a kind of evidence. I mean, the level of evidence is very low, but for example, as I told, if you're talking about an unknown NPS and 100 people tells you that they got headache from consuming this kind of NPS, it's a kind of evidence. So it's like.
If I may, yeah. Oh, sorry, Andre. I think we don't have drug checking in the way my colleagues have described in Ireland currently. There is funding being made available, and the state is looking at the model that will be implemented. but I don't know what it's going to be like and when it will be. So it is down to talking to people, finding out what's happening, getting them to describe the effects of the drugs that they're using, as I said, and yeah, just there is rich information talking to people who use drugs, but we really cannot just take the word of one person. We need to triangulate and find out as much as we can, and that's why I was talking about this kind of idea of gathering intelligence from people who use drugs. I mean, appropriately,
Andrea, I think had a. You were still on mute, Andrea.
Just the thought really is that we talk about trends, but we can also talk about alerts, and what that often reflects is the severity of the adverse event. I mean, as Dominique showed, that even if you only had 5 people who reported that they were getting really sick from smoking what they thought was normal weed, then surely that would merit putting out some sort of comment that there is that this phenomena is occurring. And I think when we think about a trend, once an alert has been put out, then that's where you can start building more evidence by finding other events that mimic the one that has been reported, and through that you can try and evaluate whether or not it's a local phenomenon, perhaps just one local dealer who's decided to bulk up some legal weed with something less pleasant, or whether actually this is something that is further up the supply chain. I think all of the speakers have commented about the strength of actually speaking to people and understanding what is going on. And I'm very aware at the EMCDDA, we regularly feel very far away from that experience and that knowledge. And when we meet people within the various networks that we're in, we learn a great deal, because they start talking about, well, last month we were sitting with and this happened, and we were, and that's very valuable information. That's not, you shouldn't, I don't think, be afraid to flag up something if it's only in 5 people or whatever, because it may be in 5 people in your locale, but in the next city or in the next country, it may be another 5 or whatever, I think that's the challenge, really. Anyway, that's just a thought about the severity. The severity should actually be leading us to act, not be afraid of crying wolf, really.
That's a very valuable feedback. Thanks.
If I may add a few lines, talking about trend doesn't necessarily mean that negative developments happen. We're talking about, for instance, spice in Zurich causing all kinds of problems. Yes, that's an event that needs to be alerted. The alert is necessary. But on the other hand, also developments could take place in a better way. For instance, people stopping from injection of cocaine to smoking or something like that. So a trend is not necessarily a negative issue. This is just what I wanted to say. And I'm very interested to find out whether civil society, they have this information more than any other organization, but how is the best way to move forward with a single event, an anecdotal thing, or a trend, how to step up and to influence policymakers to start doing something.
So I think that it depends about the relationship that you have with the stakeholders that can be involved. For example, in Spain, we have very good relationships with the government and with all the agencies, public agencies. And also we have a long trajectory. So finally, what we can say that this could be a trend is being taken seriously. So finally, it's about our trajectory, and it's about how you are integrated in the general public prevention. But for example, for us, it's important to see if it's really a trend, when after several actions, this trend is not changing. For example, I remember, you will also remember, because this was several years before, but you were still there. So when the MDMA appeared, this crystal MDMA out of the blue, finally, we were always used to MDMA pills, and suddenly appeared a new form for MDMA. And it was so strong, that we even need to do a specific leaflet for people who were taking MDMA to explain that it was the same substance, but only a different form. But finally, it's once, with the alerts mainly, when you can see perfectly, that once you are publishing, with this Superman pill, with PMMA was something big, but once you did the action, this pill disappeared. But it was not really a trend, but when you can see that more and more, and the time is passing, and finally this is there, you can see that it's a trend. But it needs time always.
But that was an alert, because that was a specific situation when a pill contained no MDMA, but 173 milligrams of PMMA, absolutely lethal. The trend would be, which is still happening, is that, as Tony already mentioned, or somebody else, cocaine is getting increasingly pure, or MDMA is getting increasingly pure, and ecstasy tablets are getting increasingly strong. That is a clear trend. But this is done by drug taking services. But how would you deal with those situations when there's no drug taking services? Because the majority of the countries still in Europe do not have proper working drug taking services. And how to do your work as a civil society organization to inform the people, and to warn maybe, or to get into contact with policymakers to spread the message about something happening on the market.
That's what I asked myself also. I don't want to overestimate the importance of drug checking services for monitoring purpose, but what would have happened in Switzerland if there would have been no drug checking services, for example, for this phenomenon of synthetic cannabinoids? I have no idea who else would have detected it. So it's like, I don't know. But it's an interesting question to ask ourselves.
If I may, I suppose, influencing change and influencing policy takes time. Andre alluded to that in terms of getting data together and at a national, international level, and takes time. The drugs market is far more dynamic than that. And it is the case that the evidence takes time to get together, and then the policy response takes time to implement. And by the time you've done that, drug trends have changed again. I suppose the information I'm talking about, when I was presenting, is about information that is useful to harm reduction services, to drug services, to service provision locally, to commissioners of services locally, rather than national policy perhaps, or it will be ultimately useful, but that will take time, or international policy. So what you can use that information yourself as a service provider. Harm reduction information needs to be revisited. It's pretty standard, but it needs to be revisited time and time again. When different drugs are more prevalent than they were, because you have new users and people need to know about how to stay safe. And we might think we've covered that, but we haven't in recent years. Do you know what I mean? So you have to go back and revisit things. But we haven't mentioned the C word yet, COVID. The COVID was very interesting for all the wrong reasons, but in terms of drug services and drugs in Dublin, particularly. I'll talk now about how we were able to change how we worked very quickly. So, for example, methadone became more accessible in Ireland, and in Dublin particularly. Went from 12 to 14-week wait to a 2 to 3 day wait to get onto a methadone prescription. And we started to do benzodiazepine stabilization prescriptions when that wasn't allowed before. So service provision can change, and we need to maintain those gains that we had during March and April, and we have. But I think it's just trying to hold on to that idea that we can influence change locally and how things are, how service is provided once there is a willingness to change from commissioners of services from the state. And I think perhaps if we can maintain those gains from COVID, maybe we can influence change with this kind of information.
That's certainly a good idea. We are now 10 minutes over our official time, and I wanted to thank you for staying longer, all of you with us. But if I wanted just to check with all speakers, is there anything you would like a last statement or a last question that you would like to leave us with? Please. Let us know. Sure, go ahead.
I have just one thought, in that in all of these, in order to really make use of the data, you have to have a good way of actually coordinating and contacting the frontline services, the people who are actually engaging with drug users and can speak to them and gain a contact with them. For us, sometimes that's quite difficult to get a network of people in many countries who can actually gain access to them. So I guess we've worked very hard over 25 years to develop a network of national focal points, and it doesn't work perfectly by a long shot, but it is our attempt to try and do that. But I'm just want to point to the issue, and I think if we could crack that, maybe not for everything, but for specific topics, then we could get a channel that we could collate information. We could get the benefits of adding information from multiple areas together and then across time. But the trick is breaking that actually has access or is engaged in an activity that generates data anyway. You're in luck, and you're getting really the people who can actually coordinate with the people who are on the ground. That's difficult.
Mireia?
If I can add something that also is related with the reflection that Andre was doing before, that I think that even if you don't have drug checking services, because also it's so common, one person that in Sweden they don't have, we can define strategies to connect with people who are using drugs, and we need to take them under consideration. And instead of trying to spy them or trying not to get the information without involving them, I think that the experiences that we are sharing now today show that we need to involve them in the way that we can, because of course the legal framework from the checking service is not possible to every country. But try to find a way to also involve our main target group.
Thank you all. Anything else from Dan, Dominique, or Tony?
Yeah. I wanted to say something off topic, but based on what Tony just said about Dublin and methadone more relaxed regimes, we just finalized a fourth inventory of COVID measures in harm reduction services. We have done it 4 times so far. And what happened, we do not only ask for what went wrong, but also good practice and things that may stay there once COVID finally is gone. And one of the things about methadone was that the regime is more relaxed, so 7 days changed to 14 days of prescriptions. But more importantly, it's now being delivered at home. And that will become standard practice. So delivered at home rather than at methadone buses or at generalized clinics. So I think that's also a good an idea of very good practice that I would like to share with you.
Thanks, Dan. And I wanted to thank you all. I think also what Andrea has saying, Mireia, all of you, and Dominique and Tony. And then I think it's very encouraging for us that we are still in the very much beginning of trying to engage civil society monitoring of new drug trends, and it's encouraging to hear that, well, this takes time, and but we do have the most important thing, which is people who are connected to people who use drugs, who have the trust of people who use drugs. And we need, I guess, to have more meetings like this one. I feel that now we are engaging into a good conversation. We could keep going. But unfortunately now our time has come to an end, but we definitely can have more of this engaging conversations in the future. And I would like to thank all of you for your beautiful presentations, for your insights, for the knowledge you shared with us. And also thank everyone who accompanied us so far, and wish you a very good time of Christmas during lockdowns, and a good end of the year.
Happy Christmas.
Merry Christmas to all.